face, and I'm going to try to make this full screen. Could you just let me know if you see now a full screen on your side? Awesome. Very good. So, as I said, today I'm going to talk about depressive disorders. There's a lot that could be covered in this topic, but I'll try to keep it very short because I'm inspired to talk about depressive disorders because of things like this. We should be in a golden age of euthymia. We have more antidepressant medication options than ever before. We seem to have more hospital beds and clinics and day treatment programs and clinicians deployed to look for depression and treat it. We have, amongst all the mental illnesses, depression is enjoying a reduction of stigma with the ability to have treatment in your primary care doctor's office. So we should be winning and crushing depression, but instead we see that the incidence, the prevalence, any way you measure it, number of depressed people keeps rising. And very disturbingly, the younger the cohort that's studied, the more likely they are to experience depression. So it's gaining, depression is gaining, and it's affecting younger generations predominantly more severely than older generations. And also, despite things like crisis text line and zero suicide initiatives, suicide rates on average are rising, and especially again in younger generations. So it seems that we're missing something around how to think about or treat depression, and that's what inspired this talk. Again, I could do an entire textbook on this topic. I just want to offer you some thoughts and observations coming from the point of view of somebody who treats complicated or refractory or so-called difficult cases. In my entire career, the problem of the treatment non-responsive or the treatment inadequate responsive patient has been the top number one question that I get. So I'm going to share with you some things from literature informed by some practice for how we can think hopefully more completely and better around depression and its treatment. First, Pearl, that I can't overemphasize this enough. Depression, even though it doesn't end with an S when we describe it, is not a single disease. There are many kinds of depressions and many pathways to depressions. So many so that I came up with this device or this illustration I call the depression stadium. So if you go inside the stadium and you look at the field, all the symptoms are the same. So everybody will have very similar symptom clusters. They'll have depressed mood, low energy, and so forth. So it looks the same, but you get to it from different entrances. And if you want to get out of the stadium, it's probably easier to leave by the door that you came in. So certainly on the lower left corner, we can see that biochemical disturbances like serotonin dysfunction are relevant, but you can also have a similar clinical picture if you have a life that is absolutely devoid of meaning or purpose, if you push away your friends or have no friends or have significant losses, or if you have personality factors that make you prone to excessive worry and rumination. Again, you can have the same clinical picture from multiple different pathways, and it's challenging to solve the problem of lack of meaning or purpose by giving somebody a medicine which will boost their serotonin levels. Another reason to emphasize, or another point to emphasize when trying to impress you with the idea that depression is not a single disease, is that just look at how on the left we used to define depression and on the right how we do it these days. So from a 1980s or 1990s or 1930s, I mean, the historical view of depression was a condition obviously characterized by low, depressed, blue mood, but going along with inability to fall asleep or with early morning awakening, however you slice it, insomnia, lack of sleep, lack of appetite leading to lack of weight and decreased activity and slow speech, and everything slows down. So all the changes are, if you will, in one direction. Contrast that with modern definitions of depression as espoused in DSM-5. You can have not only lack of sleep, but you can have excessive sleep. You can have not only loss of appetite, but you can have higher appetite. You can have weight loss or weight gain. You can have slowing or you can have agitation. So it's looking at that, it's really hard to make the case that we're looking at the same disease now as we did in, say, 1980, and that it could be any change of sleep or any change of mood or any change of appetite really opens up the possibility that, as I said before, what we call depression is not a single disease, it's multiple diseases. So let's look, without getting too deep into those weeds, let's look at some major subtypes of depression that exist within this kind of nondescript heading of depression. First of all, nowadays is called melancholic depression. Um, it is a kind of depression that, if you will, is the classic picture of depression. People tend to have difficulty falling asleep. Quite often, they'll wake up uh, earlier than intended. Almost invariably, there's a loss of appetite, a loss of interest, extreme slowing of speech and of motion. And from, it's hardly in the textbooks anymore, but if you talk to older school psychiatrists, they'll tell you that constipation is common in that kind of depression. And just pay attention as you go forward in your practices, you'll start to notice that. And also, interestingly, what we call diurnal variation. So people with melancholic depression will typically wake up early and feel undescribably awful. They describe feeling like lead or very heavy. And with great frequency, the mood sort of lifts. It doesn't get as bad. And in some cases, actually, people say, just before I go to bed, I don't feel depressed at all. So when you see this constellation of symptoms, that's melancholic depression. That tends to be the medication, that tends to be the kind of depression that antidepressants work for. Amongst antidepressants, tricyclics probably are best for that kind of depression. And electroconvulsive therapy, ECT, is spectacularly helpful for this kind of depression. In my practice of ECT for melancholic depression, my success rate, and by success I mean remission, was 95%. From literature, 80%, and you can get this within 3 weeks of treatment. So I'll reemphasize ECT later on, but melancholic depression is a specific form, and it has specific treatments that work better than others. We also have this version of depression that goes by the name atypical depression. So this is the kind where you sleep a lot or you have a big appetite, particularly craving for carbohydrates. People with atypical depressions are often described as very sensitive to interpersonal conflict, or to rejection, or very sensitive to the possibility of rejection. There's also a great deal of there's also more minute to minute or hour to hour mood variability. So people with atypical depressions will oftentimes, if something good happens, or if they think about something good maybe happening, you'll see a lifting of mood. So that's a different kind of symptom cluster compared to melancholic depression. And it looks as if MAO inhibitors are probably the most helpful kind of medication for this variant of depression. So those are some words on some of the subtypes in depression. Now I want to talk about thoughts. Thoughts matter. An old advisor from way back when told me he was an analytically trained person, and he wanted to impress upon me the idea that thoughts matter. And he says, I don't think you'll ever be able to find a medicine that will change somebody from a Democrat to Republican, or Republican to Democrat, or so on. And his point was that there are, with thoughts and ideas and beliefs that are repeated and rehearsed, these become significant and sort of have a life of their own outside of biology. Depression is maintained by habits of thought or behavior. I think for many people, it starts off as quote unquote chemical imbalance or genetic tendencies to have overreactive physiology, which leads to a feeling of heaviness and constrained thoughts. So for many people, it does start off with biology, but if it goes on for weeks or months or years, or recurs over the course of a long time, then thoughts change. We also know that people with depression tend to be very good at remembering negative emotion material. They tend to be very good at noticing things that are negative emotion material. And so I say we have a memory balance that kind of makes a person like a genius for remembering negative information, and they behave as if they have a form of dementia for noticing and remembering positive affect or positive emotion information. That's just part of the condition. But if this goes on for a long time, then you begin to expect that everything is going to work out badly, or that you are inherently a defective person. And then when you're noticing more negative information, this becomes a way of confirming these beliefs that are dysfunctional. And so if this goes on for some time, you wind up with a set of a cognitive set and a behavioral repertoire, which makes you more susceptible to re-experiencing depression. And unless we intervene with those thoughts, particularly when they're well rehearsed, we can't expect really good gains with medications, because medications don't change ideas. In my work with people that have had non-responsive or complicated courses of depression, I'll usually ask them, have you been involved in psychotherapy? Of the ones that know what I'm talking about, they'll usually say, yeah, I have. So then I'll say, great. Tell me, when you're working with from your work with your therapist, tell me, what's the cause of your depression? Have you been given a framework for understanding, like, the kinds of thoughts or behaviors that lead you to be in depression, and does your therapy address those things? And almost everybody, again, my patients are the ones who didn't get better from other things. Almost everybody that I ask that question to has no idea what I'm talking about. They tend to describe their therapy as various forms of supportive listening or befriending, which is nice, and for some people can work. But we have a host of psychotherapies that have been tested that get at core cognitive or behavioral features of depression. So getting people involved in evidence-based psychotherapy will help them to uncover those depression-promoting beliefs, look at the extent to which depression will change their relationships or their relationships affect depression, and begin to address those things. Look for things that are modifiable in environment, or belief systems that can be modified therapeutically. Very important bullet point number, my pointer's not working, but the second to last bullet point, identifying strengths that can be used to support recovery. This is the essence of what's called supportive psychotherapy. It's actually very useful. The last bullet point is that's a nod to what's called acceptance and commitment therapy, realizing that part of that struggling with negative emotions then can sort of perpetuate them. So being more acceptive of distress while working toward deploying behaviors that are more healthy. All of them are great. So the point is that there are many kinds of evidence-based psychotherapies that can be used. It becomes a matter of then trying to assess what are the specifics of thoughts, behaviors, meanings, relationships that are going on, and then trying to match the therapy to the patient. And like medications, if therapies aren't working within a certain period of time, we should change the approach. Great, it's an overlooked concept. Another thing that is really common in refractory or difficult or complicated depressions is that we miss important information. Um, Probably the most important missing piece is personality disorders or personality characteristics, which predispose to depressive moods, or social conflicts which don't help or which hurt mood. Um, so I really detest the phrase personality disorders, but that's the language that we use, and they have criteria, so I'll go with that. Personality disorders are rampant in cases of apparently non-responsive depression. Some estimates are that they're present in some estimates, 70% of cases. In the Karubal data, 85% of people in outpatient settings were thought to have personality disorders. The Rossi paper shows that avoidant, borderline, and obsessive compulsive disorders, personality disorder characteristics, were present in people with depression. And it's not like 30% had one and 30% had and 30% had another. So it's not like 90% had these disorders. It was quite common to find a single person with depression who had two personality disorder criteria, or sometimes three. So these things can be co-occurring, and it just reiterates the fact that ideas matter, patterns of behavior matter, and we need to offer the right kind of psychotherapy. A question that I get with disturbing frequency usually comes from students, and I won't name the name of the textbook that they read, but they seem to come from students of a particular author. And they usually say, isn't it true that if a person doesn't get better from antidepressant medications that they probably have bipolar disorder? And no, it's not true. If you look up the criteria for bipolar disorder, you'll find that not responding to antidepressant medications is not part of that. This idea was actually generated by pharmaceutical companies in the mid 2000s or in the aughts, and they were highlighting the fact that a lot of people with bipolar disorder spend more episodes in depression than in mania, and that retrospectively, it appears that many people who wind up with a bipolar diagnosis had their first episode being a depressive episode. And it's true that bipolar depression doesn't respond as well to antidepressant medications. So pharmaceutical sales representatives were able to spin these together. Lots of CME courses were designed around this concept, and it is true in some cases, but as pointed out, between 30%, 50% or 70%, depending upon which study you read, of refractory depression involves dysfunctional attitudes, beliefs, or personality characteristics. It's far more common that you're looking at real depression, not as some sort of to be revealed bipolar disorder, and therefore we should not jump to that diagnosis simply on the basis of medication non-response. I point this out because I get the question so many times that I think is necessary to just make that clarification. And we should always keep in mind that no matter what, everybody has different responses to medications, and it's possible that we can prescribe antidepressants and they actually make depression worse, or at least appear to make depression worse by creating psychiatric adverse effects. This is a question that I get a lot from people who are affected by depression. They'll say, I take, and it just makes me feel worse. It saps me of my motivation or energy. A alarm. Do keep this in mind, because certainly that can make the appearance of non-response. And then another thing is that suicide is inherent. Suicide risk is inherent in severe depressions. In questionnaires, we tend to respond to depression by prescribing medications, and when suicidality is present, recommending hospital stays, which are focused on this very nebulous concept of stabilization. But the evidence that you can reduce suicide risk by prescribing antidepressants actually simply doesn't exist. People probably have heard about the possibility that they could increase suicide risk. That is a statistically small, but statistically significant finding, particularly applicable to young adults or adolescents or children exposed to these medications. Nobody knows exactly why, but it's a finding, so that they can, particularly in younger audiences, increase the risk for suicide. But nobody, to my knowledge, has shown me studies. I've not seen a study that says we looked at a large number of people that were prescribed antidepressant medication and looked for suicide attempts or completed suicides versus some comparison group. It makes intuitive sense that it would exist, but the data they're not there to support that. And just in my work with people who are admitted to hospitals with suicidal thinking, usually the suicidal person has encountered some kind of problem or situation that they can't resolve, and suicide is a kind of a solution, if you will, to these unsolvable problems. So it sometimes can take a great deal of time to try to find out exactly what is the crisis point that is unresolvable. But once one understands that, then helping to actually solve it, or to simply frame the problem in a way that a person can be less disturbed by, is a very high yield maneuver. So those are my thoughts on the suicide topic. Now I'm going to turn to a couple of things that should never have been forgotten, which tend not to be utilized as often as they should be. So I'll let you in on some secrets. Tricyclic antidepressants are really, really good medicines. They certainly have more side effects than modern offerings, but many observations, many studies, and certainly the clinical practice experience from people like me who do treat people with refractory depression says that they probably are more effective. It just simply better medicines for relieving depression. They also come with the advantage of being able to give blood levels that are clinically meaningful. So we know that if we give somebody, for example, amitriptyline, we can know that we've given them the right dose for their body size and metabolism capacity, and we can then hold that dose at a certain period of time. And if they're not getting better, we certainly know that we've dosed it adequately to alleviate the issue. For people that don't, so anyway, it's an underutilized option. As I said earlier, atypical depressions, MAO inhibitors are good for those. They're oftentimes forgotten about these days. And then finally, ECT. It really is just astoundingly effective treatment. When I was in medical school, I got nauseated when I saw ECT being done. Just the concept seemed to be barbaric to me. But I noticed that my patients who were on their way to dying from having lost 40 pounds and having ileus and so forth, they went from being nearly catatonic to being fully functional within a couple of weeks. It is for people that have melancholic depression, the success rate is near 90%. For people with other depressions, it can be 60%. But compare that to the STAR-D data on likelihood of medication in somebody that's failed 2 medications, and it really is a night and day difference. I emphasize this because in my practice as an ECT clinician, I will have had, a common referral is somebody who has suffered for 6 months or 2 years and has so much damage to their well-being and to their occupation and to their family. There's a lot to be lost for severe depression, and I just wish that they would have come to me sooner, because when it comes to melancholic depression, I can promise a 80% to 95% remission within 3 weeks, and the episode is done. TMS is a lot less spooky for many people, and certainly doesn't involve anesthesia and inducing seizures in brains. But it also is better than medications, but it is, there's the response and remission rates, 29 versus, say, 30% and 20%. So it's good, but it's, there are other options as well. So to conclude, depression is not a single disease, and it shouldn't be treated like there's no one single pathway for depression care. It can start as biology, but is maintained by habits of thought and behavior. Oftentimes, treatment resistance or medication non-response involves missing diagnoses. Personality factors are one. Anxiety is a huge one. Obsessive compulsive tendencies are another one. And not to mention the myriad of environmental and social stressors. Don't forget to think about tricyclics and MAO inhibitors. If you are, I assume if you're listening to this, that you do treat people with depression. So I encourage you to find a pathway to ECT that you can refer people to, because your patients will get better faster if they get that treatment. The ones that are treatment resistant, and your patients who are not responding to medications will get better faster through ECT than through continued medication trials. Evidence-based psychotherapy it should be first-line treatment for mild to moderate depression. For mild to moderate depression, in fact, you probably ought to do that and not use medications. But for almost anybody with depression, they should be given the benefit of psychotherapies to look at the cognitive factors that propagate depression and increase further risk. And when you're and at the beginning, but certainly if they're not responding to treatment as planned, go and make sure you're not missing any important diagnoses, and treating those can be can be quite useful.